Okay, we're joined by Professor Patrick Thornton. Professor, loads of interesting things at the conference today. The drug that came up quite a lot was venetoclax. A lot of talk about that. It's not actually available in Ireland at the moment. Just tell us a little bit about the background to that.
Okay, so venetoclax is it's a tablet. It's one of the newer treatments for CLL, and it works incredibly well. It works in all patients, and it also works in patients where chemotherapy doesn't work, people with, for example, p53 deletion. Strictly speaking, it is available to a set population of patients in Ireland. It's part of a large trial we're doing called CLL13, and this is a trial as part of the large European German CLL study group for newly diagnosed fitter patients with CLL. And venetoclax is the backbone for 3 out of 4 of the treatment arms of that trial, and the information on that trial is available on the Cancer Trials Ireland website. However, it is only a clinical trial, and that is only for new patients and fit patients. This drug is useful in patients who have relapsed. That means their CLL has been treated previously and their disease has come back again. In that scenario, currently we would treat patients with something called the B-cell receptor inhibitor. One of those drugs is ibrutinib, the other drug is idelalisib. Those drugs work very well, but when they stop working, that is where we need the drug venetoclax. The efficacy of this drug has been proven very, very well as a suitable drug to use in those situations. It's much better than chemotherapy, it works well in relapse, and it will salvage people who ibrutinib or idelalisib has failed. Better than that, if, for example, we have 2 B-cell receptor inhibitors, ibrutinib and idelalisib. If one of them doesn't work, you could argue, well, use the other one. That will only salvage a minority of them, whereas using venetoclax will salvage much more of those people and rescue them. So it's a treatment which, now we're coming to the 4th and 5th year of ibrutinib and idelalisib, we're actually starting to see people where this drug has stopped working. And currently in Ireland we have a licensed drug. In Europe it's licensed in America, but we're unable to provide that drug for Irish patients. The reason for that is that when drugs go through a license, they have clinical trials, they're licensed drugs, we're allowed to prescribe them, but the state has to agree to fund them, because these drugs are very expensive. You couldn't afford to pay for it yourself, and so the state has to agree on a price with the pharmaceutical company to fund this drug. And obviously the state has other pressures of other things to fund, but it's currently in that limbo where the drug has a license but the drug is not funded, and patients cannot avail of it.
Is that likely to change soon?
Well, one would hope it's going through what's called a technical review, and so therefore the benefit and the economics to pay for that drug, whether we're able to do it, whether we feel the HSE feel it's justified to do it, that is the current process that's going on. But unfortunately, in anti-cancer medicines, this seems to take longer and longer, and other pressures come in, and that's the problem we have. And I don't think hematologists are unique in that complaint. Everyone will think their drug is the most important, and whether it not even be in cancer, whether it be in multiple sclerosis or cystic fibrosis, there's a pot to go around, and we have to make the case for our own drug, and that's where we are at the moment.
Okay, Professor Thornton, thanks indeed for talking to us.
Thank you.